Welcome to the Safe at School, Back to School Nurse Panel discussion presented by your American Diabetes Association. I'm Dr. Henry Rodriguez. I'm a professor of pediatrics and director of pediatric endocrinology at the University of South Florida Diabetes and Endocrinology Center here in Tampa, and co-chair at the ADA Safe at School Working Group. I'm co-moderating with Dr. Christine March, who's a pediatric endocrinologist at UPMC Children's Hospital in Pittsburgh, and is a member of ADA Safe at School Working Group. As you probably know, the ADA Safe at School program is devoted to protecting the legal rights of students with diabetes so these students may learn and thrive in a safe and healthy school environment and be treated fairly. Today, our panelists, school nurses from Arkansas, Colorado, Maryland, Pennsylvania, and West Virginia, will share their best practice insights with us and provide recommendations for CGM use, specifically remote monitoring in the school setting. Remote monitoring refers to Bluetooth connecting a student's continuous glucose monitor sensor to their cell phone, allowing the school nurse or trained school staff member to view their CGM data on a separate device. Our hope is that today's panel discussion will provide school nurses with increased knowledge, skill, and confidence to best support students with diabetes and thereby enable these students to optimize their education and safely participate in all school-sponsored opportunities. This evening, our co-presenters will share their expertise and tips on using remote monitoring of CGM in the school setting to best support students with diabetes. School nurses have an important role as advocates and key providers and coordinators of diabetes care in the school setting. School nurses, parents, healthcare providers, and students working together can make sure our children with diabetes are safe at school. I ask that you please type your questions in the chat box, and our panel members will do their best to answer your questions at the end of our panel discussion. Also, please view the chat box for links to resources that will be provided throughout our program. This program is also being recorded and will soon be available for viewing on ADA's website and social media platforms. Finally, the information provided by this program does not constitute legal or medical advice. For medical or legal advice, please seek out a medical provider or attorney. Thanks so much to our panelists and to all of you for attending. I'll now ask our panelists to introduce themselves, starting in alphabetical order. Sarah Birch.
Hi, my name is Sarah Birch. I am a registered nurse in the state of Arkansas. I am the Assistant Director of Nursing for the Rogers Public School District here in Arkansas and also the current President-elect of the Arkansas School Nurse Association. I've been a nurse for 19 years, a school nurse for 11 years, and last school year I had the privilege of caring for 5 students with type 1 diabetes, most of whom we remotely monitored with a CGM, so I'm really excited to be part of this discussion.
Thanks, Sarah. Next, we have Diane Chorney.
Hi, everybody. Thanks for joining us this evening. My name is Diane Chorney, and I am the diabetes resource nurse, or one of the diabetes resource nurses for Jefferson County Public Schools in Colorado. We now have 2 additional diabetes support people, and our district has had an interesting sort of transition with our view on remote monitoring. We had been very opposed to it, very sort of resistant. And then over just the last year and a half, we've really embraced it. And I'm really excited to talk about what that transformation has looked like for our school district. So thank you.
Thanks, Diane. Jen Lang.
Hi, I'm Jennifer Lang, and this year I will be starting my 6th year as a school nurse with the Montgomery County Department of Health in Montgomery County Public Schools, and it will be my 19th year as a registered nurse. Prior to school nursing, I worked in oncology, postpartum, and pediatrics. And as a school nurse, I've worked with students with diabetes in pre-K all the way up to seniors in high school. Some of these students had pumps and/or CGMs, while others relied on finger sticks and MDI. When I'm not at work, I enjoy spending time with my husband, 3 kids, and dog.
Thanks, Jen. Wendy Robison.
Hi, my name is Wendy Robison. I'm a registered nurse and nurse practitioner in the state of Pennsylvania. I've been a school nurse for 25 years and a nurse for 33 years. I have worked with children and students with diabetes, CGMs, pumps of that nature. And I'm very glad to be part of this discussion. I think it's the future for our children And I think this will enlighten many of us out there that have either fears or some concerns regarding moving forward with this device. So thank you so much for attending.
Thanks, Wendy. And last but not least, Carol Wood.
Good evening. Hi, my name is Carol Ward, and I have been a nurse, I'll just put it this way, 40 plus years, and proud of it. I've also was a school nurse for 21 years before taking the coordinator job at the West Virginia Department of Education, where I'm over all the school nurses in West Virginia. And I want to say thank you very much for being here tonight. And I hope you go away with a lot of information and can learn the positive things with CGM monitoring.
Thanks, Carol. I'll now turn things over to Christine for our first round of discussion questions.
Thank you so much to all of our panelists. We're going to start with a question for Carol. So Carol, how has your state established supportive guidelines for remote monitoring by school nurses? How did they go about it?
So in West Virginia, a lot of things come out with legislation. And many years ago, the legislation made a law that we in West Virginia would have what we call a specialized healthcare procedure manual. And the coordinator at the Department of Education, along with the Council of School Nurses in West Virginia, any new procedure, any new medication, anything to that degree, we provide a policy, or not a policy, but a procedure in specific specific things that need to be completed in the schools with orders. So it was very easy once CGMs were ordered, and then the nurses and with guidelines came up with a procedure that nurses follow in every school. So we're very fortunate in West Virginia that it is through legislation that all of this was passed, and that we have procedure manuals for each individual procedure, like I said, within the school system. So it was really simple for school nurses to grasp, and they have a step-by-step that they can follow while they're monitoring or learning about CGM work.
Thank you, Carol. We have a question now for Wendy. How is the decision made as to whether remote monitoring of a CGM will be done in a given school for a student?
In our school district and in Pennsylvania, decision making is collaborative. You have to look at each child uniquely. What are their abilities, and your status of your nursing department, the ability of even Wi-Fi, that kind of thing. But generally, to be honest, the decision making is left to the healthcare professional in the district, which I happen to be the only one. I have a great relationship with administration, and we have a discussion regarding the use of these and the benefits of these. Just like we have smoke detectors in schools that alert us to be preventative, we established that CGM remote monitoring has the same effect. It's proactive instead of reactive, which we all enjoy. It's actually a prescriptive kind of thing. Prescriptions, we give medications to patients, and whatever the cause may be, we're actually behind the 8 ball on most things. This is actually something that we can use to stop an event. So all of the benefits, it's an early and easy adoptive practice. So, the school districts, I guess for privacy issues, things like that, they have to weigh those items out as far as device use and that kind of thing. But it's a collaborative approach with parents, providers, and school districts.
Well, and our next question is for Sarah. So Sarah, how did you get started with remote monitoring in your district?
Yeah, so I have a feeling that many school nurses across the country kind of got started the same way I did. I got started with the CGM when they were just kind of starting to pop up in our district. We had like one or two in the district, but I personally had never had any experience working with one. Our district did not then and still does not currently have a policy that directed us. What happened was the parents of a newly diagnosed kindergartner called me, contacted me, said, we'll be enrolling in your school. So I set up a meeting to meet with these parents. We went over the DMMP and we went over the CGM in great detail. They wanted me to remotely monitor their child in school. And, because that, I knew that this was an up and coming technology and I knew this was part of the student's daily life, I was very eager to incorporate this into their 8-hour school day or longer, whatever we were doing at school. But I was very open and honest with the parents that I was new to this technology and they were new to it too, but this was part of their daily life. So they were my immediate go-to resource for education and kind of hands-on troubleshooting of that device as far as how alarms are set, how we tinker with the device and troubleshooting that needed to be done. The CGM itself was written into the DMMP. So that was kind of the first step about learning how to troubleshoot it with the parents and then reviewing that DMMP. Asking a parent to go over that device, I find very, very helpful. Not only does it teach the nurse, if you're new to CGMs, about that specific student and that specific device, but it also is a really great way to build a relationship with that parent because you have the opportunity to collaborate together on those things. Most CGMs will have their websites have some kind of tutorial, something for nurses to follow to learn about that particular brand and how it operates. Also, your diabetic educators and your clinics are great go-to resources when you have questions about a CGM, but I really encourage nurses to seek out those educational opportunities in their area to get the professional support and the education that they need to use one. Now, after I learned how to use that CGM, the next thing I needed to do was get a device because I did not have a device and I didn't want to use my personal device. So I went to my principal, told him what I needed, and he provided me with an iPad to use in my school. Now, our district, we are fortunate that they understand the importance of incorporating CGMs into a student's individualized plan of care. So those are provided for our nurses. Laptops and tablets are becoming very commonplace in schools anymore, but that depends on where you live and the funding in your building. So everyone's going to be a little different on what kind of access that they have, but I encourage people to ask. If your district has limited funds or does not provide you with a device, I encourage people to talk to their PTO or PTA. You can do a fundraiser and even look out into the community and even businesses in the community. It never hurts to ask. There are usually devices out there that you can bring in and use in that regard. But CGMs are becoming standard practice. So last school year, as a matter of fact, we had 31 students in our district with type 1 diabetes that had a CGM. And 20 of those we were remotely monitoring on campus. So it's part of our daily life. Again, our district doesn't currently have a policy, but we want every student to have a 504 associated with that CGM to help provide those guidelines until we can adopt a policy. And hopefully that'll be in our near future.
Thank you, Sarah. Some great ideas. And then our next question is for Jen. So I think this is nicely following what you were just saying. Who monitors the CGM in the school setting, where you are, and which staff are usually trained to respond to the alarms or to look at the CGM data?
This is a great question. And honestly, the answer will vary greatly depending on the age of the student, their history, their treatment order, their other health needs, and the setting that the student is in. In Montgomery County, school nurses do not continuously monitor CGMs throughout the day on their phone or any other device. They use the CGM data to calculate insulin doses at meals or correction per the DMMP, and then review it as needed throughout the day, again, per the DMMP and what that directs them to. School nurses also train other staff to respond to alarms and then delegate to them when appropriate. Trained staff would typically include teachers involved with the student, like classroom ones or specials. It would include the counselor, paraeducators that work with the student during the day, as well as administration and other assigned staff members. These individuals would all know how to respond to a CGM alarm per the DMMP. So again, the DMMP kind of directs everything. In Montgomery County, school nurses can be assigned to anywhere from 1 to 3 schools and often have numerous students at each school with diabetes or other health-threatening health conditions life-threatening health conditions that require daily care and or medications. There are times when a student's medical and or family situation dictate the need for critical staffing, which would be a private duty nurse or paraeducator from the school system. The determination for additional support would be made through the 504, like Sarah was mentioning before, or IEP process, and then the school system would hire the paraeducator or private duty nurse. The school nurse is a critical member of that team that makes this decision, and the team also includes MTPS staff and works with the family to follow the DMMP. This may come into play in situations like a young, newly diagnosed child that may not be aware of their hypo and hyperglycemic symptoms, or could be a student that has had poor control at home, which causes instability at school, or could be a student that has other health needs, which we do have in some of our programs. This individual would still be required to follow the DMMP, which would entail responding to alarms, checking the CGM at certain points during the day, but would not include continuously monitoring it, since we have, the entire school that we continually monitor, or, their health conditions.
Okay, I'm going to turn it back to Henry for our next round of questions.
All righty, well, thanks. The next question is for Sarah. So how do you set expectations and or plans with parents of students who you're remotely monitoring?
Oh my goodness, this is such a good question, and it is one I hear nurses ask all the time. Because sometimes we are asked or presented with expectations that really are not reasonable accommodations in the school setting, because they can interrupt the care that we provide for our other students. As was pointed out, we have a lot of students under our care, a lot of which require very specific nursing care. So diabetes management is going to look different at school than it's going to look at home. However, remote monitoring of CGM is a reasonable accommodation for the school setting. But the school nurse cannot be expected to respond to every single data point or to watch that CGM just around the clock, because we do have other responsibilities that we need to engage in. All students with diabetes need a 504 plan. And the reason is because the DMMP is going to tell the school nurse the medical care that that student needs to be safe throughout the school day. But that 504 plan is going to detail and specify how that medical care is accommodated in the school setting. So this includes the expectations of both the school and the parents in a spirit of cooperation, coming together to write that individual plan. But we should be responding to the CGM alarms. And so that plan needs to include how those alarms are set, how responding, how often, and who is responding. So collaborating on these points, I think, does a lot to reduce anxiety for both parties in that setting. Sometimes I think frequent communication initially with the family helps to build a relationship of trust. For example, if you are checking a child's CGM prior to PE and you notice they are 90, double arrow down, you're going to treat that child, but you might go ahead and send that parent a message in some way and say, hey, his blood sugar is 62. I've done A, B, and C. It's going to alarm, but I've got him and we're doing good. Because we have to remember the parents are also grappling with this diagnosis, and all they hear is an alarm. They have no idea what's going on during the school day, what's been done or what's not been done. Initiating an explanation about what's going on in the care setting can put patients at ease in any nursing situation, even in the school setting. So eventually that kind of frequent communication can become less frequent as we build that trust and establish that relationship of trust with that parent. But if you do find yourself kind of at an impasse with some expectations you don't feel like you can reasonably accommodate, what I recommend is that first and foremost, you be empathetic. And you need to be an active listener and recognize that these are valid, real concerns for these parents. What I tend to do is encourage them and refer them back to their provider so that they can get additional support, education, and even clarify orders. And then we're going to invite them back and continue to build that individualized healthcare plan for that student. But whatever you decide to do and however you decide to set those expectations, I think that you need to prioritize building a relationship of trust and collaborating with that parent to ensure that that student has a plan that's going to keep them safe and keep them learning in the classroom.
That's super, Sarah. Thanks. Understanding that things are different, I think, in different areas, different institutions. The next question is for Jen, related. What's your experience with remote monitoring of student CGM, and when should a school nurse or trained staff member when should they be looking at the readings?
So CGMs were designed to keep students with type 1 diabetes in range, not continuously monitor them throughout the day. In Montgomery County, a school nurse or trained staff member should be looking at the CGM when it alarms, we all know that, at designated times per the DMP, or when the family may request it, such as in the morning when they get there, depending on if they rode the bus or parent dropped them off, or when the student has symptoms that would indicate hypo or hyperglycemia. Just like any other student, each student with type 1 diabetes is different. They have different life experiences, different families, different orders, and often different methods of treatment. A few years ago, I had a very young student in pre-K who had difficulties in her home life, which caused her blood sugar at school to be unstable. Days she would be high and other days she would be low. And this was complicated by the fact that she was completely unaware of her symptoms of hyper or hypoglycemia. She was also young and fairly newly diagnosed. Due to the amount of care that she needed during the day, I advocated for and received a private duty nurse who managed her daily care and monitored her CGM when it alarmed, at meals, at certain times per the DMP, or as needed throughout the day. Another year, I had 3 kindergarten students in one class who were all type 1, had type 1 diabetes, one of them being newly diagnosed during the school year. In that case, we were able to have a paraeducator hired to monitor their CGM as ordered and needed throughout the school day. She was also provided a device at that point to monitor their CGM, since she needed to be able to see all 3 of them at once. Not all students require an extra staff member to review their CGMs during the school day. This past year, I cared for a newly diagnosed older elementary school student, she was 3rd grade at the time, who was able to listen independently for her own alarms as she had been doing at home, and then she would alert an adult if she heard it. This was something that the school team felt comfortable with, since she was doing the same thing at home, and per her parents, it had been working really well so far. Her teachers and other staff that worked with her were then trained to not only listen for her alarms as well, but also trained on how to respond if it were to alarm. Her CGM was then reviewed by health staff before lunch, before recess, before PE, before dismissal. Towards the end of the year, I was even delegating some of that to her teacher, since everything had been going so well. In her scenario, with permission from her family and the student, we also educated her class about diabetes, and the students in her class knew that if they heard the alarm, they were to notify a staff member immediately. Educating her classmates about her alarms and devices was probably the most beneficial tool in her care, since they were the ones close to her that would hear it easily, and it made her a little less embarrassed when it would start to alarm. Yeah, that's it. Thank you.
Thanks, Jen. And as I mentioned, it's remarkable to me, just in speaking to all of you, just how different it is at each of your institutions. I wonder, I just invite others, are there different ways that you kind of address this issue? They're all thinking intently. Well, we'll circle back to that at the end, no doubt. So if I turn to Wendy, if I may, changing things a little bit, from the student's perspective, what do you think the pros and cons of CGM are, and how do we address the student's perspective as well?
Sure. So there are many pros and cons, and I speak with my students. The pros are that you have some surveillance, you have some backup, you have a device that helps you manage. You don't have to come in and do glucometer sticks all the time, that kind of thing. And that's a pro for sure, but it's also a con because we're creeping on them all the time. And they know if they eat something at lunch, we're going to see it, and so it's intimidating. I wouldn't want someone to watch what I'm eating and things like that. So especially with your peers, I mean, we all know, I have teenagers, I have young children, and they're just children, and they are going to make mistakes, and I don't want them to feel like this defines everything. There's enough pressure in school that they need to have some bit of freedom in some point within a safety net. But so it's a pro and a con in another way. But most recently, what I've talked to students about is that they're taking phones away from children now. so that the majority of students in school don't have their phones on their person, except for the students who have a CGM and use that to remote monitor and have alarms. So they feel identified now in this very weird way where they were out, with everyone and it was commonplace. And now they feel like, oh, they know, and people question, why do you have your cell phone? So that is a phenomenon that's just started this year with that pullback of cell phones in schools. So I think it'll be interesting to see going forward this year how that plays out. And then, for tests, standardized tests or anything like that, they do have that available to them. We need to know, prior to testing, how are they? Are they stable? Those kinds of things. And, that's either a pro or a con. It's a pro for a student that they're stable before they take a test, but then other students perceive that maybe that they're getting out of something, if they need to go and get stabilized. I think a pro for teachers would be that, it's a very objective measure. It's not a subjective complaint anymore. Like I have to see the nurse. It's, we have data. So I think in many ways, there's many pros and cons, but I think this year is going to be an interesting year to see how these children and students work through all of these changes as far as that goes. But yeah, I think that gives them agency, though, a little control when they don't have much of it. So I tease them sometimes, even the teenagers, I say, listen, I use apps all the time on my phone. I use it when I drive because sometimes I drive too fast, and I use Waze, and it tells me when a police officer there about to give me a ticket, and they laugh. So I tell them to check themselves before they wreck themselves, and they laugh about that. But yeah, I mean, with anything, any medical device that comes out, there's always pros and cons. And I just would like everyone out there who's listening, just, try to do your best to understand it, to work with the parents. The relationship that was discussed earlier is key, but this is the future. I mean, we've adopted other things. And so I think that communication piece and that relationship is key with the students, with the parents, providers, and your administration.
Thanks, Wendy. And so, yeah, I'm creeping. That's an interesting term for me. I would have used Big Brother myself, but I get it. I get it. I'm curious as to our other panelists. The cell phone issue is coming up more and more. Here in the state of Florida, where I'm at, our county recently instituted a cell phone restriction, but thankfully there was that medical exemption. And so I'm just curious as to the rest of you. I'm assuming you're starting to see this. It's early in the school year, I realize, but anyone else want to weigh in?
I'll weigh in on this. I recently had a conversation with the Arkansas Children's Hospital, and they're getting lots of calls from concerned parents about what's going to happen with my child's CGM. My particular school district in Rogers, Arkansas, we've always had a policy about cell phones, and we don't want students using their cell phones in class, but we have not adopted this more rigorous policy that we do see popping up in adjacent school districts and counties across Arkansas. But I will say this, that, you've got to write that CGM in that 504 plan. I think that really is what solidifies it as a medical device that supports that student. But as a school nurse, I'm going to advocate for students to be able to have access to that. I do agree, that there are some pros and cons to it that we're gonna, and it's new territory for all of us, so we're gonna kind of have to navigate this together. But again, communicating and collaborating with parents and the students, particularly our older students, is going to be essential when we cross these bridges.
Thanks, Sarah. Anyone else?
Yes, I can make a comment. In West Virginia, we just recently, and I was asked about a policy, and like Sarah said, it is becoming more rigorous. But what they're going to do in West Virginia for those students that have a medical device that requires a cell phone usage, they are permitted. And they will not be denied or restricted from usage with that cell phone. So kudos to the Department of Education.
Thanks, Carol. I'm gonna turn to Diane now and ask you, what have you been surprised with since you started using remote monitoring at your school?
So as I mentioned in the introduction, our school district was pretty reluctant to embrace remote monitoring of CGM. We actually had some difficult conversations with families who had asked that we do it, and we were resistant and said, no, this is going to be too much of an additional burden on our health techs because our model is a delegation model. We don't have nurses in every school, so we are delegating diabetes care to unlicensed personnel. And there was a concern about what that would look like in our health rooms. And then we had a couple of parents that were pretty insistent, and we thought, okay, we can give this a try. And then what we found is every school that we started remote monitoring in, everybody loved it. Really, in terms of looking at pros and cons, I think the pros very dramatically outweigh the cons. We've had a few little issues, but I think overall, it's helped us keep kids in class. We talk about keeping tushies in seats, which is key, keeping kids in classrooms, accessing the education. It's actually been very beneficial for our health techs and our backup staff. So we have our health tech in the health room. We have our front office secretaries who are also providing diabetes support. So I think the concern was around looking at these devices and monitoring them constantly. But as others have spoken about, we're responding to alarms, and that's what we're training staff to do. You're responding to the low alarm, we're responding to a high alarm, and then intervening when you can to hopefully prevent a low. We use what we call the catch it clause. So if somebody does notice that the glucose is dropping rapidly before an alarm, they can intervene at that time and hopefully prevent the low, keep the child in class, accessing education. So we've really seen it be just an incredibly positive step forward. And I keep questioning why we were so resistant for all of these years. And we've been aligned with our Colorado standards of care for diabetes support in the school setting. And even up until last year, the Colorado standard said that remote monitoring should just be considered in very specific situations, maybe a student who's special needs, a student on an IEP, a very young child. But it wasn't very much presented as this is a beneficial tool for most students. And then the standards that came out just this past summer, actually it's still summer, just last month really spoke about the benefits and that we really should be sitting down as a team with parents to say, is this something you want to consider? Because it can be very beneficial for the child, keeping them in class, and also beneficial for the staff providing support. They're not, especially a school that's got maybe 7, 8, 9 students with diabetes. If we're using an iPad and we're able to watch those numbers, well, I shouldn't say watch those numbers, respond to the alarms on the device, it keeps the health tech from running all over the school looking at kids' phones because she can see that information right from the device. So there's set check times to look for, say, Susie or Johnny, and the health tech can just be looking at that device and know that student is in range, I don't need to disturb them, or that student is trending low, I need to probably go in and do an intervention. So we've seen it be incredibly positive.
Sorry, I had myself muted. I really do appreciate that. And I think as we all appreciate, as devices have evolved over time, not only can you set an alarm for an actual low, but for an impending low. And that certainly does allow us to be proactive in how we assist these students. So thanks very much for that.
And maybe one other thing I'll add, I think a concern of parents is what happens when my child's out on the playground during recess, because those alarms maybe aren't heard by the child. The paras that are out on the playground may not hear, but if there's a device in the health room, that health tech can hear the alarm and then call out to the folks on the playground to say, hey, Susie needs some glucose tabs. So it's been, I think, a comfort for parents as well.
Super. Thanks, Diane.
Sure.
Appreciate it. I'm going to turn this back to Christine. It's all yours.
Thank you. Thank you. Okay, so we're going to go back to Carol. We're going to ask, is it okay for the school nurse or the health aide to remotely monitor the CGM data from their personal device?
Okay, that's a good question. Ideally, no, because it is a personal device. It's not a school device, and You would have data on a personal device. And then it makes the nurse responsible. And there's also a concern with, like I said, with data, and even with a HIPAA violation. So it's best practice to have another type of device that schools like Sarah had spoken about earlier. If your schools don't have that extra device, there are ways to possibly get the device for that CGM monitoring, but definitely it's not wise to use your own personal device for monitoring.
Thank you, Carol. And going back to Diane, who is responsible to respond to the CGM if both the nurse and the parent are monitoring remotely? So kind of setting up that communication plan.
Yes, setting up that communication plan. And we're actually doing a lot of that this week as students are returning to school toward the end of the week. What we present to parents is that really it's for us in the school setting to respond initially. And that we typically say to families is if you're not seeing some indication that someone has responded to that alarm, please feel free to call the school. And one of the things that we've started to do is to let families know that somebody is on it, somebody's responded to the alarm, is to use the child's phone and just send a thumbs up emoji to the parent to indicate like somebody's with your child, somebody's responded to that alarm and is treating that low. So I think that that's a concern for families because you're seeing those numbers, the glucose is dropping. Is anybody with my child? What's happening? So we typically say it's school staff's responding initially. You're always welcome to call with a concern, but we're hopefully going to be able to get that thumbs up emoji to you as quickly as possible so you know someone is with your child and taking care of them.
And a follow-up question to that, let's say you are dealing with some other kind of emergency, Diane, or this could be a question for someone else, and that CGM alarms that you were remotely monitoring in your health office. How does that then get handled in the school setting where you all are?
So our model is, we've got our health tech, and then we have at least 2 other people in the building who are delegated for diabetes care. So typically it's going to be your front office secretaries. So there's a lot of communication. So someone is like, I am dealing with this bloody nose. Can you then quickly go respond to this low CGM alarm? So it's a lot of coordination and communication and really good communication. And everybody has a radio in the school. So we are able to radio somebody who is maybe out on the playground. So it's very good, clear communication.
Henry, do you want to take back over?
Sure. So I'm just curious on that point. For our panelists that maybe don't have, I don't know, the cadre of folks that Diane has to assist her, how do you address that in your own schools?
At our school district, we're fortunate in Arkansas, or in my school district, not all across the state, but in my school district, for the majority of our schools, we have a nurse for every school building. So we are very fortunate in that regard. So the responsibility does fall to the school nurse when we're available to be monitoring that CGM. But like Diane was saying, I think the important key is whether you have a lot of staff to support you or a skeleton staff to support you, is you have a plan in place. You need to be communicating with your staff what that plan is, but with the parent as well. Because if the nurse is responding to, an emergency, doing CPR, a broken bone, something like that, there needs to be a plan in place. Just like there's a plan in place if you're responding to a broken bone on the playground, if Johnny comes into your office needing his inhaler. Who's there to help assist that student? And most of us do have those kind of plans. So those plans are kind of what our district uses. We utilize staff. We have kind of a hierarchy of staff of who's the first go-to person, the second go-to person, and just have that plan in place, whether that's at school or even remotely, like on field trips and things like that. We have a plan in place on who is responsible for responding if the nurse is not available.
Anyone else? Okay, I'm going to move to a section here that we wanted to, we got some comments in that really, I think, address some misconceptions and worries that have been expressed by school nurses. And so I'm going to invite all of our panelists to jump in on this one, but I'll start with statement number one. My health room will look like a telemetry unit if I start following CGM for everybody.
I can jump in on that because I think that question came from one of our nurses. I think there was concern that there would be devices set up all along the desk of the health tech. And what we have found is that one iPad can monitor multiple students. So it's an iPad, it's not very big, it just sits on the health tech's desk. And we're, trying to maintain that confidentiality. Of course, we don't want other students coming into the health room to see that. But it's one device or one phone. And I think there was this idea that there would be monitors all over the room, and that has not been the case. So we're able to follow, 6, 7 students on one iPad. That's not very large. And it hasn't felt like a telemetry unit. So yeah, that's been our experience. So
Thanks, Diane. How about the next one? I'll be expected to watch these numbers all day.
I guess I can speak to that a little bit. I addressed it a little bit earlier in your previous question. I think sometimes, number one, I know when I was first introduced to a CGM, I was tempted to watch that sucker all day long. Like, I was nervous about it and I was still learning about it. I was learning the student and learning their trends and kind of how their body works, because everyone's different. And you also have parents who, approach nurse with those expectations that they want them monitoring it all day long or every 20 minutes or, whatever the case may be. But we do, the CGMs are actionable items. Those alarms are actionable items. It's not expected of any nurse to be monitoring and watching that CGM screen all day long. We simply cannot do that and keep up with the host of other health concerns that we have going on in our office. But, there is an alarm. And when there's an alarm, we have an action. We check and see what's going on, we assess from there, and then we, intervene as needed.
Thanks, Sarah. And so I think you alluded to this, but the next one is, I'm worried about the liability if I miss a low alarm.
I mean, I can speak to that again. If someone else wants to jump in, Diane, go ahead.
okay, I think that might be a question from our district again, too. I think that was a concern. I think the health techs were worried, do I have to carry this device with me when I go to the bathroom or and we made it very, very clear that the device is going to stay in the health room and the alarm should be audible. So it's heard in the health room, and that the front office secretaries who are right there can also hear it. And that it's a tool that we add to sort of a tiered layer of support for that student, because we have our routine check times with students. We have our routine dosing times with students. So it's not as though the remote monitoring is taking the place of all of these other supports that we have in place. So it's one more tool to support safety of a student. It's one more tool to support keeping students in class. So I think that helped people stop thinking of it as a liability concern. And I think that maybe was the biggest concern people had, is this idea that they had to be watching constantly. And if they missed a low alarm, that the repercussions would be grave. And we're saying, no, there's an alarm that the child might hear, the teacher will hear. This is not the only system in place to provide support to keep a kid safe in school. It's another tool that we have that we add to the interventions that we've already got in place. So I think that helped people not feel so concerned about that. If you miss a low alarm, somebody else is going to hear the alarm from the child, or the child will report to the teacher. It's another tool. So.
Thanks, Diane. And you already covered, you don't have to take the device into the bathroom with you.
Yes.
Thank you.
Does not need to go.
Now, there's another comment here. My health aide is an older lady who's not tech savvy and will be scared off by the technology. I'm afraid she will quit.
I think this just kind of goes back to education, like educating them why the CGM is important, how simple it is to use, and reviewing it as many times as they need it to understand, how it works and how it is actually benefiting the care that they give.
And then I think we've addressed this pretty well, but a device in the health room will just create more work and responsibility for my health aide.
I'll jump in here. I think for us, we've seen that it's actually made our health tech's job easier. So they're not running all over the school, checking kids in the class, looking at their CGM value on their phone. It's allowing our health tech to stay in the health room more. And I think our health techs really speak to how it's made their jobs easier. And they actually like having access to those numbers. They feel more comfortable with the safety that they're able to support for their students.
I'm just curious, have any of our panelists experienced, overwhelming work from the introduction of CGM and remote monitoring?
No.
Well, that's good news.
No, I'll echo what Diane is saying here, and that I think it's helped a lot because you're not only reducing the actual physical activity of going to that child, finding that child to check that blood sugar, but you can check it right there, check up on them, see how they're doing. So it reduces the workload on the nurse in that regard, but it also reduces the interruption to the child's education, which is part of a nurse's job. Our job is to support education, and so in that regard, it is an excellent tool. And just like Diane was saying, that this doesn't create more work for the nurse. It's just another layer of being able to observe something we are already doing. So I think it condenses the workload for the school nurse and provides a level of safety and comfort for those who are utilizing it.
One of the comments in the chat came from somebody who doesn't have the luxury of having a school nurse. So I think some of you have addressed this a little bit, but I wonder if in your own systems, school systems and districts and so forth, if that's come up and how potentially do we navigate that?
I would advocate for a school nurse. I think.
So would I, but
because there's so much
yeah.
more care to be done. It's not a matter of just watching a device. That is something that, like, if you're an older nurse like myself, and not to call out anybody, Carol, who said you're out there with me, but before we had telemetry units, I mean, we could have a patient who has an issue, but we're responding after the fact. So yeah, it's taking care of children who have diabetes is more than just monitoring the CGM. So I would advocate for a nurse in that district, in that building, as number one. But I mean, that's not, I don't know where they are in the world, rural areas, whatever, but I think there's always room for solutions creatively if we can come together with relationships and explain the needs. So I feel for you if you don't. That would be terrible.
And I think all of our panelists, I don't want to speak for all of you, but feel free to object. And I think all of our attendees really would advocate for that. But I think, Sarah, as I think you mentioned, I mean, there's somebody in your front office staff that's helping out, and so I think communication, I think, is what I'm hearing here is a central theme, and setting expectations and really coming together to come up with the best plan for that student at that school.
Yeah,
We have been.
I'm sorry. Go ahead.
Go ahead.
Well, I was going to say that you consider your state laws as well, because I know it varies state to state on whether or not you can train an unlicensed person to provide diabetes care. In the state of Arkansas, we do have a law that allows us to train unlicensed personnel to provide care with the permission of the parent and the doctor. individually assessed, of course, depending on that student's needs. So, unfortunately, not everyone does have access to a school nurse, but I would encourage you to look at your state laws and reach out to your state representatives and those that are making these laws and really advocate and push for the need for school nurses in every building. I think school nurse access is an equity issue, and every student should have access to a school nurse. We need to get pushing that message out there.
Thanks, Sarah. Christine, did you want to pick up some additional questions?
I was going to say we have been getting tons of fantastic questions in the chat from people who have been listening in. And so I wanted to actually start asking a couple of these. Now, one question that's come through a couple of times is about field trips. So, that's, if you're accompanying a student onto a field trip, you may have an iPad, but that doesn't have, connectivity if you're out kind of in the world. So how do you handle remote monitoring with field trips?
In our school district, we don't take that device with us on a field trip. So maybe the health tech, whoever is delegated for diabetes support, might be going on that field trip, and they're just going to be checking in with the student more frequently. They're going to be within earshot of that student, so can hear that alarm, or checking in with that student, because that is one thing. We're not sending the devices out on the field trips, and it really hasn't been an issue. So I don't know what other districts are doing, but we have just managed with more frequent check-ins with that student on the field trip.
I think it's important to realize that, for those students for which there's remote monitoring potentially going on at school, as you mentioned, they have their device, receiver, cell phone, that's going to alarm. So the individual accompanying them on that field trip should be able to respond to that alarm.
Completely agree. So another question that came through had to do with there were a few that had to do with communication, actually, with the parent. And so one actually specifically came for Sarah about, what kind of device are you using to actually communicate with the parent throughout the day? And somebody else also asked, is there any concern about liability if you're using your phone to text back and forth with the parent?
Yeah, so that's a great question. And I always think that there is some concern about liability if you're using your own personal device. And I think it can cross some boundaries between that nurse-patient relationship. You don't want people to have your personal number. I'm sure they don't want you calling them at, all hours. And I think there needs to be kind of a boundary there. I think it's important. In regards to, HIPAA versus FERPA. When you take that device home, if it's got personal identification or identifying information on it, and someone in your home is seeing it, or you're out in public and someone sees it, that could be a potential HIPAA violation there. But how I personally communicate with parents, and I did not come up with this, I have some incredible people that I work with that are much smarter than me. Google Voice is great. I'm sure there are other apps out there that you can use. But I can text a parent. That's one of the reasons I have my iPad, is I will use Google Voice or an app similar to text parents and just give them like that thumbs up emoji, or just kind of let them know what's going on. Most of the time, people these days respond by text. If a parent's in a meeting or if they're grappling with their other children at home, it's easy just to kind of look at that and go, it's alarming. Oh, I got a thumbs up from the nurse. We're good. So the other thing I like about that is, outside of diabetes, but you can also send medication reminders like, hey, we're running low on insulin, we need more snacks, or, hey, the pump site came out, or whatever the case may be. But that's what I typically use. You can put that on your phone, but I typically just do it on the iPad. So whatever your school allows and will allow you to hook up to that device, there's a lot of things out there you can use.
I do the same thing. I use either Remind or Class Dojo, things like that. Having said that, we don't have that closed loop system yet with the Dexcoms and other devices. So if there was a way to embed that into the software of that app where you could send a message like, took care of it, and then, it would be a true closed loop kind of communication device. But until that happens, and I'm not smart enough to do that, so we'll see.
I think one of the questions that I'm seeing here, actually a couple of times, is that, and this has been a theme, I think, throughout our discussion. And by the way, I'll mention this now, and we'll mention it at the end. But I wish all of our students with diabetes had nurses like you all. But the issue is, so if there is difficulty perhaps in getting folks to agree, I think the central theme here has been communication. And so it all stems from the provider and the health provider and the diabetes medical management plan, and then really making sure that that's implemented in a way that's going to allow that student to fully participate at school. And as I think we all realize, that's a challenge. And I think there are a number of individuals that have been commenting on the chat that's sometimes a challenge. And so I think, at least from my perspective, the message should be that folks should come together and realize that they want to do what's best for that student, and take into account obviously the DMMP and the resources that are available at school, and certainly advocating for more. But other thoughts on that?
I have one thought. I tell the school nurses in West Virginia, it's hard for people that teachers or anyone that does not have, they're not medically inclined. And school nursing is unique to begin with. So I always have them compare, if they're going to be talking to an administrator, or whomever it might be that is, that really doesn't understand the medical side of it. So what do they understand that could be comparable? And that would be anything like with teaching. So would you want a child in your classroom to not have, whatever it might be? Well, this is how I feel about the child that needs, a device monitoring. Um, so if you can make that analogy of going back and forth, it's just like, for example, when I have my nurses, they'll, they want to make a presentation to the board, and they don't really know how to explain how many diabetic students there are in a classroom. Well, the easiest way to do that is to take a classroom and fill the seats with students with diabetes. And then it makes them more aware. So anytime you want to advocate for your student, and you're not dealing with someone that has medical knowledge, the best way to do that is get on their level of whatever their expertise is in the school, and then make that comparison.
Well, before we wrap up today, does anyone else want to, share any other thoughts or comments about their experience with remote monitoring to close us out?
I can share. I think, again, just because we were, again, so reluctant, and I still question where was that coming from, but we have really embraced it. And I think just having had those few experiences where we saw the benefits for students and for our staff, and I'm really happy to speak with anybody who wants to reach out to me to kind of share a little bit more what our experience has been, because we've really transitioned 180 degrees and really seen the benefits of remote monitoring. So I think just addressing the concerns, and I'm hoping that this panel discussion has helped some folks understand what some of the concerns have been and how we've addressed them. But it's really been beneficial for students and for our staff. So.
Thank you, Diane. Well, we're right at the top of the hour. The American Diabetes Association thanks all of our panelists for sharing their time and their expertise today. And thank you to all of you for attending this very important back to school session. We hope that the guidance and the information provided today has been helpful to you as you prepare to have your students back in school. And please know that the American Diabetes Association is here for you. So a link to this session will be soon available on our website and social media platforms if you'd like to view it again or share it with others. And for more Safe at School information and resources, you can go to diabetes.org/safeatschool, call 1-800-DIABETES, or email askada@diabetes.org. Thank you and have a good night.
Thanks, everyone.